Well, good morning. My name is Dr. Robert Fontana. I'm a professor of internal medicine and the medical director of liver transplantation at the University of Michigan Medical Center. And I'd like to chat with you this morning about the diagnosis and management of patients with esophageal varices. I have no financial disclosures related to this presentation. What I would like to specifically cover with you today is a review of the incidence and pathophysiology of developing esophageal varices in patients with chronic liver disease, and in particular, an importance of the understanding of underlying portal hypertension as a driver of variceal development. In addition, we'll review some data on the recommendations for screening for varices in various patient groups, and also the use of beta blockers and band ligation to prevent initial and secondary bleeding from esophageal varices. Then we'll briefly review the principles of management of patients with variceal bleeding, including the role of antibiotics, emergent endoscopy, and TIPS procedures for patients with refractory bleeding. In terms of the pathophysiology of varices, most patients who have varices have underlying portal hypertension. Portal hypertension most commonly develops in patients who have chronic liver disease with a fibrotic and/or cirrhotic liver. The reason that varices develop is that the blood flow that goes through the portal vein into the liver is reduced and the pressure goes up when there's increased resistance to intrahepatic blood flow. As a result of this, these venous structures dilate up and channels form in the lining of the GI tract and in the retroperitoneum. And these channels are what we call varices, or collateral means of decompressing the elevated pressure. Now, there are patients who can also develop portal hypertension from heart failure and other venous outflow problems, although that's less common than intrinsic liver disease and cirrhosis. In addition, patients who have problems with the circulation into the liver, with, for example, portal vein thrombosis, can also develop evidence and manifestations of portal hypertension. However, by far and away, greater than 90% of patients who have varices have underlying chronic liver disease and specifically cirrhosis with the distorted microarchitecture of blood flow through the liver. Overall, esophageal varices are more likely to develop than gastric varices due to their proximity to the portal vein. When we say the word portal hypertension, we're specifically implying a gradient across the liver. And the way that you can measure the gradient is through a wedged free hepatic vein pressure and a wedge pressure using a catheter. Technically, we all have somewhat of a gradient for positive blood flow through the liver, and normal pressure gradient would be anywhere from 2 to 6 millimeters of mercury. However, when you have chronic liver disease, the gradient goes up due to increased resistance, and clinically significant portal hypertension that is associated with the risk of GI bleeding is defined as greater than 12 millimeters of mercury between the wedged hepatic vein pressure and the free hepatic vein pressure. When we talk about grading varices, you'll see in the literature various schemas. When you do an endoscopy, some patients may have no varices, as is shown here on the left-hand side of the slide. And then there are patients who have small varices. Small varices are varices that will be obliterated with insufflation of the esophagus. Large varices, on the other hand, tend to occlude the lumen of the esophagus, although they do not cause any dysphagia or actual mechanical impairment of food boluses. And medium varices are obviously intermediate size. When you insufflate the esophagus in patients with large varices, they do not obliterate or flatten out. With medium varices, there's marginal improvement in the size of the diameter of the varices. In terms of the rate of variceal development, it's been shown in multiple prospective studies that in patients with cirrhosis who do not have varices at their surveillance endoscopy, that as many as 7 to 8% per year will develop small varices. And in patients who have small varices, the rate of developing medium or large varices is also approximately 7 to 8% per year. When we look at the prevalence of underlying varices in patients with newly diagnosed cirrhosis, you can see here from the slide that it varies markedly depending upon the severity of liver disease. So patients who have compensated cirrhosis that we call a child's acirrhotic have overall about a 30% likelihood of having underlying varices at an index endoscopy. And you can see here from the color gradient in the slide, the majority of patients have small varices. When you then look at patients who have moderate decompensation, which is a CTP score of 7 to 10 or a child B cirrhotic, the frequency of having medium and large varices increases substantially, as does the overall incidence of varices, approximating 50%. And then in patients with truly decompensated liver disease who have a CTP score of greater than or equal to 10, which we call a child C cirrhotic, you can see that the incidence of varices may be as high as almost 80%, with a fair proportion having large and medium varices. Hence, our suspicion for varices increases as the severity of liver disease worsens. Because of this bulk of information, there are several practice guidelines in terms of management of patients with chronic liver disease, including an American Association of Study of Liver Disease guideline that was recently updated in 2007. And then specifically, when you look at that guideline, you'll find various recommendations, including who to screen for varices. What is clearly recommended in the standard of care is that any patient with newly identified cirrhosis should have a surveillance upper endoscopy or EGD. At the time of the upper endoscopy, triaging is then suggested so that patients who have medium or large esophageal varices, which are at greater risk of bleeding, should be placed on a non-selective beta blocker such as Inderal, Timolol, or Nadolol, or undergo band ligation if you feel that they will likely be beta blocker intolerant. If, on the other hand, you do the endoscopy and the patient has no varices, then it is recommended that if they're decompensated, that they undergo an annual surveillance due to the data that I just showed you. Also, if they have small varices, which do not mandate use of beta blocker prophylaxis, it's recommended that a repeat endoscopy be performed in 1 year to determine if they've evolved into medium or large varices. If on the first endoscopy the patient has no varices at all and is a compensated cirrhotic, then surveillance endoscopy is recommended every 2 to 3 years. With regards to the frequency of varices in one of the most common underlying liver diseases in the United States, there is actually a prospective trial that was recently published in 2006 demonstrating the frequency of varices. This study, called the HALT-C trial, enrolled patients who were non-responders to prior antiviral therapy into a prospective randomized controlled trial of maintenance interferon versus no treatment. Amongst the 1,016 patients who were enrolled in the study, there were approximately 500 patients who had bridging fibrosis. And when you looked at the endoscopic findings, much to everyone's surprise, nearly 16% of these patients had underlying esophageal varices, and the frequency was higher amongst compensated HCV cirrhotics, with 39% having underlying esophageal varices, the majority of which were small. When you then looked at associations with the presence of varices, patients who had a platelet count greater than 150,000 were very unlikely to have large varices. The negative predictive value was 99% in both the bridging fibrosis and cirrhosis patients. Clearly, assessing platelet counts along with histology can give you a sense of the likelihood of having underlying varices. So from this data, the implications for screening are all patients, again, with HCV cirrhosis, including compensated patients, should undergo a surveillance endoscopy for the presence of varices. In addition, patients who have bridging fibrosis and evidence of significant portal hypertension with a platelet count of less than 150,000 should also undergo surveillance for varices as well. With regards to recommendations for beta blocker use in patients with cirrhosis, there are several important points to be aware of. First off, there was a recent study published in the New England Journal of Medicine looking at patients with compensated cirrhosis who did not have varices at entry, and they were randomized to Timolol versus no beta blocker therapy and prospectively followed for several years. And what was shown in that study was that Timolol did not prevent the development of new varices, so therefore pre-primary prophylaxis to prevent varices from development is not effective and is not recommended in patients with cirrhosis who do not have varices at their index endoscopy. Amongst patients who do have medium or large varices at their index endoscopy without a history of bleeding, there are multiple randomized controlled trials, including meta-analyses, demonstrating that the use of non-selective beta blockers can clinically reduce the likelihood of bleeding within 1 year from 30% in untreated patients to 14% in patients who are treated with these non-selective beta blockers. When you're using beta blockers in patients with chronic liver disease, The goal is to try to reduce the patient's resting heart rate by 20 to 25% by titrating the dose up, but not to slow the heart rate below 60 beats per minute. It's been well shown, however, that in patients with cirrhosis who frequently are hypotensive and vasodilated, that some patients may be intolerant due to the development of significant symptoms of fatigue, hypotension, and even shortness of breath if they have underlying reactive airway disease. Therefore, in patients who are intolerant of beta blockers, another therapeutic option would be band ligation. Band ligation has been directly compared to beta blocker primary prophylaxis and is associated with the similar efficacy of only a 14% rate of bleeding 1 year after band ligation versus 12% with beta blockers in a large meta-analysis. In addition, because it's an intervention and not a chronic therapy, there's actually fewer adverse events in patients who undergo primary banding versus beta blockers. Clearly, in patients who you think will be intolerant or already have bradycardia at rest, band ligation would be another therapeutic option in patients who've never bled, who have medium to large size varices. In patients who've already previously bled, there's also multiple studies demonstrating the efficacy of using beta blockers to reduce the risk of bleeding. The way in which this works is beta blockers reduce cardiac output and also reduce splanchnic inflow and lead to a relative hypotensive effect in the portal circulation. When you look at secondary prevention in multiple meta-analyses, the risk of rebleeding in patients who receive beta blockers is only 20% versus 40% in patients who did not receive beta blockers. So clearly, beta blockers are also indicated in patients who have had bleeding previously from esophageal varices. The risk of bleeding in patients with underlying varices is certainly related to several factors, including the size of the varices, with patients with medium or large varices most likely to bleed, patients who have endoscopic stigmata of thinning of the varix that we call a red whale sign, and then patients who have Child-Turcotte-Pugh score of greater than 10 that we categorize as a Child-Turcotte-Pugh Class C patient with more severe liver disease are also more likely to develop variceal bleeding. All of these factors are actually related to a simple physics principle called Laplace's law, where the tension on the actual variceal wall is related to the radius, which is the size of the varix, multiplied by the pressure, which is the severity of the portal hypertension, divided by the wall thickness, which is related to the presence of blebbing or red whales. With regards to actual bleeding episodes, less than 50% of patients will spontaneously stop in the absence of intervention. These patients need to be hospitalized in an intensive care unit with therapy offered quickly. With regards to outcomes in patients who have variceal bleeding, outcomes have significantly improved over the last 20 years, with an estimated current short-term mortality of 15 to 20% during their index hospitalization. Patients who have more severe liver disease are more likely to die from either aspiration, progressive encephalopathy, sepsis, and/or acute renal failure. In patients who survive their initial hospitalization, their prognosis is guarded, with a 30 to 50% one-year mortality, and hence any patient who develops variceal bleeding should be urgently referred for liver transplant evaluation. When we look at evidence-based management principles for patients with variceal bleeding, we'll see that antibiotics can not only improve the likelihood of developing infection, but also significantly improve the likelihood of survival. Endoscopy has been shown to reduce the amount of bleeding and the risk of rebleeding. Vasoactive drugs such as somatostatin reduce the transfusion requirements and overall rates of bleeding. And as I showed to you before, both primary and secondary prophylaxis with beta blockers will reduce the risk of either bleeding with primary prophylaxis or rebleeding with secondary prophylaxis. Of note, however, is certain things do not work and should not be used in patients with variceal bleeding. Studies have shown no benefit whatsoever to the use of sucralfate for patients with acute bleeding, and also the use of recombinant 7A, which is a thrombin inhibitor, has not been shown to improve outcomes, and due to the cost and potential risk of this medication is not recommended for patients with variceal bleeding. As you can see here, we don't really have evidence to support the use of proton pump inhibitors, but there's good reason to believe that they will be effective. With regards to patients who present with liver disease and evidence of upper GI bleeding, it should be presumed due to varices until proven otherwise. Because these patients can bleed massively and have a high inpatient mortality, development of rapid access with large bore IVs and/or central line is recommended. In addition, If the patient has an underlying coagulopathy, they should receive fresh frozen plasma to get their INR less than 1.5. And if they have thrombocytopenia, they should receive platelet infusions to maintain a platelet count of greater than 50,000. With regards to packed red blood cell transfusions, the target hemoglobin should be 8 to 10, not higher than that, because studies in animal models have actually shown that hypertransfusion can actually worsen portal hypertension and increase the risk of bleeding. With regards to immediate triaging in the emergency room, all patients with cirrhosis and evidence of GI bleeding should immediately have an NG tube passed to determine if they're actively bleeding. There is no significant risk of causing varicose bleeding by passing the NG tube. In addition, either IV or oral PPIs are recommended, knowing that 25% of patients with liver disease who present with upper GI bleeding are actually bleeding from a non-variceal source, such as a Mallory-Weiss tear or peptic ulcer, and hence we do want to use PPIs quickly in these patients. Oftentimes, an endoscopist will want to have the stomach cleared in addition to lavage, and IV erythromycin or Reglan can assist in the successful completion of a therapeutic endoscopy. All of these patients should always be placed in the ICU for hemodynamic monitoring, and certainly intubation of more tenuous patients is recommended prior to endoscopy. Infections are a common cause of morbidity and mortality amongst patients with liver disease, including those who present with variceal bleeding. At the time of admission to the hospital, 20% of patients with cirrhotic variceal bleeding will be actively infected, and during their hospital course, 70% will develop evidence of infection, with urine, ascites, and respiratory pathogens being most commonly isolated. Therefore, there have been multiple studies looking at the utility of broad-spectrum antibiotics given for 5 to 10 days versus no antibiotics, and multiple meta-analyses have shown that use of broad-spectrum antibiotics reduces the rate of infections, but more importantly, reduces the likelihood of death in patients who have variceal bleeding. The greatest benefit is seen in patients who have more severe liver disease and when they're given prior to the endoscopy. With regards to the specific agent, multiple drugs have been studied, with cefotaxime, levaquin, or Unison demonstrating efficacy. In addition to rapid administration of antibiotics, pharmacological therapy is recommended right from the emergency room using splanchnic vasoconstrictors. The drug of choice in 2012 would be sandostatin or octreotide, which inhibits splanchnic blood flow. It's initially given as a bolus dose followed by a continuous infusion for the next 5 days. There have been multiple studies comparing octreotide to vasopressin, and overall it is apparently a bit more efficacious, but more importantly is associated with fewer side effects, such as vascular ischemia that happens with vasopressin. Octreotide versus sclerotherapy has also been studied, and they have equivalent rates of controlling bleeding, rebleeding, and improving mortality. And then certainly octreotide in combination with endoscopy has been shown to be better than endoscopy alone in terms of reducing the amount of bleeding, rebleeding, but again, no benefit has been shown in improving mortality. If for some reason you do not have access to octreotide, if you're going to use vasopressin, you should also use nitroglycerin to minimize the risk of peripheral and coronary ischemia. Endoscopy is the cornerstone of management of variceal bleeding. Again, these patients need to be in a monitored environment. They're going to require IV sedation. Some will require intubation. And the likelihood of bleeding and interventions is based upon the endoscopic findings, in that patients who have large varices should undergo immediate ligation or sclerotherapy, and endoscopy is highly effective with control of bleeding in at least 80 to 90% of patients. Whether or not band ligation versus sclerotherapy should be used depends upon the comfort level of the endoscopist. They do have similar efficacy, but band ligation is associated with fewer complications, including a lower risk of infections, development of esophageal ulcers, and strictures of the esophagus in the long run. However, during active bleeding, it can be more difficult to visualize the actual varix, so some endoscopists may fall back to sclerotherapy to help them through the procedure. During their hospitalization, 10 to 20% of patients with variceal bleeding will rebleed, and patients who have portal vein thrombus or have very high gradients or are actively infected are more likely to rebleed. In this scenario, it's recommended that the patient remain in a monitored setting, continue to receive octreotide and antibiotics, and undergo urgent repeat endoscopy. At that time, the source of the bleeding can be more specifically identified as to whether it's due to esophageal ulceration from prior band ligation or sclerotherapy, or recurrent bleeding from esophageal varices. In addition, sometimes the stomach may not have been well visualized, and the patient may actually be bleeding from gastric varices, and endoscopic therapy is not effective for these patients, and urgent TIPS would be required. In patients in whom rebleeding cannot be controlled at the time of repeat endoscopy, placement of a Blakemore or Minnesota tube may be needed to slow the bleeding. In some of these patients, a transjugular intrahepatic portosystemic shunt or TIPS device may be required. As you can see here in this slide, this is done through a Seldinger technique wherein access to the central circulation is obtained in cartoon A. A catheter is then placed through the right branch of the hepatic vein into the right portal vein as seen in B. This is then dilated up using an angioplasty balloon as seen in C. And eventually a wire mesh stent is placed into the parenchymal tract to directly decompress the right intrahepatic portal vein branch to the right hepatic vein branch to decompress the portal hypertension. In terms of who should undergo a TIPS for variceal bleeding, it's generally recommended for patients who continue to bleed after endoscopy or patients who have gastric varices with stigmata of bleeding. Overall, TIPS is very effective for controlling bleeding with approximately 95% efficacy. However, not all patients may be candidates for TIPS where the risk may be very high or the benefit may be marginal. So, for example, patients who have very advanced liver failure with a CTP score of greater than 12 or a MELD score of greater than 30 are likely going to decompensate their liver function with the TIPS, and this may precipitate their demise. In addition, patients who are already in multi-organ failure have a poor prognosis and may not benefit from a salvage TIPS. Lastly, patients who have evidence of pulmonary hypertension or right heart failure will not experience benefit because the pressure from the heart will be transmitted back directly into the portal circulation and they will continue to bleed and it won't be effective. In addition, patients who have underlying HCC in the liver or known portal vein thrombosis also are less likely to benefit from a salvage TIPS. For patients who have already bled, we want to think of several important management principles to reduce the risk of rebleeding. So follow-up endoscopy with banding is recommended to obliterate subsequent varices. This should be done every 2 to 3 weeks until they're obliterated, and most patients require 2 to 3 additional endoscopy sessions over 4 to 6 weeks to obliterate varices. While you are obliterating varices, use of proton pump inhibitors given in high doses twice a day has been shown to reduce the frequency of subsequent bleeding from esophageal ulcers and is recommended in all patients. In addition, I've already shown you data that non-selective beta blockers can reduce the risk of rebleeding from 40% to 20% and should be used in all patients who can tolerate them. And then furthermore, patients should not receive ulcerogenic drugs. So for example, patients who have bled from esophageal varices should not receive aspirin, non-steroidals, bisphosphonates, or Plavix until their varices have been eradicated. And in the future, they would need to receive acid suppression, and a careful assessment of overall risk versus benefit of these ulcerogenic drugs would need to be carefully considered. As can be seen in this slide, the overall management of variceal hemorrhage can be distilled into initial resuscitation and administration of blood products and coagulation factors. In addition, patients should receive IV octreotide as a continuous infusion following a bolus, as well as broad-spectrum antibiotics before their emergency upper endoscopy that should be performed within 12 to 24 hours of their presentation. With this algorithm, 70% of patients will stop bleeding and will eventually be able to be discharged home with follow-up endoscopy, beta blockers, and PPIs. However, during their hospitalization, as many as 20% of patients will rebleed, and as mentioned, these patients should undergo repeat EGD. If bleeding can be controlled, they can then be transitioned to the outpatient setting for follow-up obliteration. However, some patients may continue to bleed in the hospital or not be controlled initially, and in these cases, whether it's due to refractory esophageal variceal bleeding or gastric variceal bleeding, they very well may need a Blakemore tube or balloon tamponade for temporization of bleeding and then undergo an emergent TIPS. From this presentation, I'd like to communicate with you the following take-home points. The likelihood of developing varices in patients with established cirrhosis is approximately 6% per year. Per professional society guidelines, all patients with cirrhosis and selected patients with bridging fibrosis and low platelet counts should undergo a screening endoscopy for the presence of varices. Beta blockers or band ligation should be considered as primary prophylaxis in patients who have medium or large varices at index endoscopy. The risk of bleeding from varices is more likely in patients with more severe liver disease. Patients who do bleed should undergo emergent EGD after resuscitation, initiation of pharmacological therapy and antibiotics. And with this approach, 90% of patients will achieve benefit. Again, overall, it's important to remember the importance of antibiotics given as soon as possible in patients with suspected variceal bleeding. For patients who continue to bleed and rebleed during their hospitalization, consideration of urgent TIPS should be provided, assuming that the patient does not have underlying pulmonary hypertension, portal vein thrombosis, or evidence of intrahepatic cancer. And lastly, for secondary prevention in patients who've already bled, follow-up endoscopy for obliteration of varices, use of non-selective beta blockers to titrate the resting heart rate down by 20% and or resting heart rate of 60 beats per minute, as well as high-dose PPIs is recommended. And lastly, these patients should not receive aspirin, nonsteroidals, bisphosphonates, Plavix, or any other anticoagulant which may further increase their risk of bleeding. And with that, I'd like to thank you for your attention and I look forward to further discussions with you. Thank you.